This week on the show, we're gearing up to try to avoid getting knocked down by winter viruses. Hey, I'm Laurel Bristow, and this is Health Wanted. Each week, we cover your need-to-know public health topics and break down the science behind them in our pursuit of better health. Fall. The leaves are changing, the night temperature is dropping, there's a chill in the air, and a tickle in your throat? There are so many pathogens that can cause a person to wake up playing the game sick or hungover in the winter months. Enteroviruses, rhinoviruses, parvovirus B19, human metapneumovirus, but we only have so much time, so today we'll simply be focusing on the big three: COVID, flu, and RSV, one of which has gotten the viral respiratory infection party started early. It used to be that we all had to wait for the weather to turn cold and wet before those viruses made their way into our warm and cozy noses, mouths, lungs, and guts. But in the last 5 years, there's been a bit of a change. COVID has gotten so used to all the attention, it settled itself into a trend of being a two-season virus, late summer and midwinter. The midwinter outbreaks happen for all the same reasons that any other seasonal outbreak happens. Things like dry winter air letting tiny viruses stay aloft and linger in the air longer, waiting for a nose to climb into. People move their activities indoors with worse ventilation to keep warm, which cozies them up to viruses as well as loved ones. And holiday gatherings give microscopic party animal pathogens a chance to socialize with all sorts of new and interesting people. I wonder if being sneezed out at a Christmas party is the virus equivalent of riding on Space Mountain, going 70 miles per hour in the twinkling lights. The late summer outbreaks happen for a few different reasons, though some are more like the other side of the same coin. For example, the end of August also sees a lot of people indoors, this time to take advantage of air conditioning. Returning to school puts kids in contact with each other to spread viruses around and then bring it home to their families, along with finger paintings of bugs and yogurts that have been left in an unrefrigerated cubby for a month. And by this time, any immunity someone may have gained from a fall vaccine or winter infection has diminished to the point that infection is likely again. Though protection against severe disease and hospitalization takes longer to decline, unfortunately, COVID is a real tricksy hobbit and mutates just enough to evade antibodies that would neutralize it fairly regularly. Wastewater data, which is a polite way of saying how much COVID people are excreting out of their bodies and into the sewer system, is currently high across the country, increasing in the northern states and decreasing in the south. While these increases have translated to an increase in both outpatient testing and ER visits, both of which actually peaked higher this summer than what we saw with last winter's COVID spike, they have thankfully resulted in fewer hospitalizations and deaths than last winter and the summer surge before it. Last summer's COVID spike peaked at around 1,300 deaths a week. Last winter peaked at about 1,000, and so far we haven't broken 500. Though death is a lagging indicator, with test positivity and ER visits trending downward overall, I'd be surprised if we hit that threshold. According to preliminary data, 2024 is the first time that COVID has been knocked out of the top 10 causes of death in the US since the pandemic began. But that doesn't mean the virus is gone. Now, it's objectively good that COVID severity is significantly lower than it has been in previous years, but it also means there's likely a lot of spread from people who might not realize they're sick. And trying to find current estimates of the prevalence of long COVID is incredibly frustrating. So I can't confidently say what percentage of the population has long COVID. Some estimates using 2023 data put it at 6%, or what the likelihood is that someone could get long COVID from an infection today. But what we do have data on is that vaccination reduces the risk that someone develops long COVID if they are infected, even in children. Which is why I always say that there are benefits to people getting an annual COVID vaccine, but I'm not going to stress out a ton if people don't want it. We live in a time where there's a lot of mixed immunity from vaccines and infections and timing of infections. So while we can say everyone could benefit from one, we really can't say everyone needs one. Although it's been 5 years since the vaccines first became available, I still get predictable questions every winter season, so I'll try to cover them quickly. If you just got COVID, you should wait at least a month after recovering before you get an updated vaccine. The CDC says you can delay vaccination for up to 3 months, so if you got COVID this summer and your 3 months will be up right before the holiday season, I suggest timing the vaccine dose for 2 weeks ahead of the first major event so that you can be well covered. Now, less complicated is the flu, our old faithful that we get a little help predicting from our friends down under. Since Australia is upside down, their flu season runs from April to October of every year, which is very convenient for us whose flu season runs from October to May, because we can use what happens there as a good indicator of what could happen here as the flu strains pack their bags for colder weather. They're like whatever the reverse of a snowbird is. And it is not looking so hot. The 2024 season was the worst influenza season in Australia since 2019, and with a few weeks left, it appears the 2025 season is likely to surpass it. The high burden of flu could be, at least partially, a result of falling flu vaccination rates. Australia has seen flu vaccine coverage drop significantly since 2020, a trend we've also seen in the US. Last year's pediatric flu vaccine coverage in this country was the lowest it's been since 2020. So it's unfortunately not surprising we saw the highest pediatric flu deaths since the swine flu pandemic in 2009. 90% of which were in children who were not fully vaccinated. Unlike COVID vaccines, though, getting a flu vaccine this year is as easy as it was last year. At the ACIP meeting in June, the members voted to recommend every American aged 6 months or older get an updated flu shot for the 2025 to 2026 season. Though it wasn't publicized, RFK Jr. did sign off on the recommendations. At the time, there was no CDC director, so that last bit of bureaucracy fell to him. So neither access nor insurance coverage has changed. One big difference we do have for this season is that you can now order the Flu Mist nasal spray vaccine for self-administration at home. The vaccine is made by AstraZeneca, and it's been approved since 2003, but was approved specifically for self-administration in September. Adults can give it to themselves, and caretakers can give it to kids aged 2 to 17, which honestly is the only age group I would suggest using Flu Mist. Unless you're an adult who hates needles and wouldn't get a flu vaccine otherwise, Flu Mist is better than nothing. But the data we have is that it really only has meaningful efficacy in the pediatric population, which is great news for those of you who are tired of holding your screaming child down in the name of illness mitigation. AstraZeneca now has a website that will ask a few questions on eligibility, ask for insurance info, and for $8.99 in shipping and handling, and then send the nose spray vaccine right to your house. Another respiratory illness common in the winter months is respiratory syncytial virus, or RSV. It's the leading cause of hospitalization in infants, but new to this season is an additional monoclonal antibody option to protect infants less than 8 months old who are entering their first RSV season and were born to a mother who did not get the RSV vaccine. This one is called clesrovimab. The mab at the end stands for monoclonal antibody, just like nirsevimab, the other option, and it's made by Merck. If you are a loyal listener of the show, you've probably heard me describe monoclonal antibodies using a matrix analogy. So let me try to spice it up with something new. Monoclonal antibodies are like DoorDashing a burrito. Instead of having to do all the preparation and assembly work yourself, the burrito arrives fully formed. In your body, this means instead of having to get your immune system to create antibodies in response to a vaccine, the antibodies are just put right in there, ready to go. This is particularly beneficial for a group such as infants who have less robust immune responses and need protection right away. And now, having two options is great because more availability means less likelihood of resistance developing, less likelihood of supply chain issues, and more competition, which can mean lower prices. Thanks, capitalism. So the current tools to protect infants from RSV are 2 monoclonal antibodies, there's no preference for one over the other, or a maternal RSV vaccine given during weeks 32 to 36 of pregnancy so that people who will be delivering during the RSV season can pass their antibodies down to the baby. An analysis by the CDC found that for the 2024 to 2025 RSV season, which was the first season where these interventions were widely available, rates of RSV in infants under 3 months were nearly cut in half. And for those under 8 months old, the rates were cut by around a third, when just 66% of infants had received either intervention. Thanks, science. There are, of course, other viruses one can get this season that aren't vaccine preventable. So be sure to do all the standard things like cover your sneeze, wash your hands, and stay home when you feel ill so you can save your sick days for playing hooky when it snows. For Health Wanted, I'm Laurel Bristow.